The following will be a discussion on fluid compartments, starting with body water distribution. Remember the 60-40-20 rule. In the textbook 70 kilogram male, water represents 60% of the total body weight, and this equals about 42 liters. The total body water can be divided into intracellular and extracellular volume. The intracellular volume, or ICF, represents 40% of the total body weight, or about 28 liters. Major ions include potassium, magnesium, and phosphate. Extracellular volume, or ECF, is about 20% of total body weight, which is 14 liters, and major ions include sodium, calcium, chloride, and bicarb. The ECV can further be divided into interstitial fluid, which is 16% of total body weight, or 11 liters. If it's easier to remember 15% and 5%, that's okay. And then plasma fluid, 4% of total body weight, or 3 liters. This picture depicts the distribution of plasma and interstitial fluid, which makes up extracellular fluid of 14 liters, and intracellular fluid, which combines with extracellular fluid to make up a total body water of 42 liters. It also adds in how the lymph system works and balances the input to output. So look at those numbers to see the relative contributions of fluid consumed and fluids output. Population with a higher total body weight percent by weight is neonates. So neonates have a higher total body water percent by weight. And females, obese, and elderly have a lower total body water percent by weight. Regarding plasma volume, plasma is the noncellular fraction of circulating blood volume. The plasma is in direct contact with the interstitial fluid by way of pores in the capillaries. The movement of fluid between the intravascular spaces and the interstitial space is determined by Starling forces in the glycocalyx. As a refresher, Starling forces are forces that move fluid from the capillary to the interstitium. PC is capillary hydrostatic pressure, so capillary pressure, and this pushes fluid out of the capillary. The symbol pi is interstitial oncotic pressure. So pi, IF, is interstitial oncotic pressure, and it pulls fluid out of the capillary. So those are the two forces that move fluid from the capillary to the interstitium. Forces that move the fluid from the interstitium into the capillary include the PIF, so this is the interstitial hydrostatic pressure. This pushes fluid into the capillary. And then there's also the pi C, so this is the capillary oncotic pressure, which pulls fluid into the capillary. These factors are used in the net filtration pressure equation, which is PC minus PIF, and then take that number and from it subtract the pi C minus the pi IF. As fluid enters the capillary, it tends to be pushed back by capillary hydrostatic pressure. Towards the end of the capillary, fluid tends to be pulled back into the capillary by capillary oncotic pressure. This assumes normal physiology. The endothelial glycocalyx forms a protective layer on the interior wall of the blood vessel. It can be viewed as the gatekeeper that determines what can pass from the vessel into the interstitial space. It also contains anticoagulant properties. Disruption of the glycocalyx contributes to capillary leak. Accumulation of fluid and debris in the interstitial space reduces tissue oxygenation. Conditions that impair the integrity of the glycocalyx include sepsis, ischemia, diabetes mellitus, and major vascular surgery. Regarding blood volume, erythrocytes are filled with fluid, but because they are contained by a membrane, they are considered part of the intracellular compartment. Therefore, blood volume is the sum of plasma volume and blood cell volume, 60% plasma and 40% blood. The hematocrit is the fraction of blood volume that is occupied by erythrocytes. Hematocrit is increased by an increased number of red blood cells, meaning polycythemia, or a decreased plasma volume, meaning hypovolemia. Hematocrit is decreased by a decreased number of red blood cells, which is anemia, or an increase in plasma volume. This is a hemodilution. Regarding the interstitial fluid, The interstitium is the space between the cells. Nearly all the interstitial fluid is a gel consisting of fluid and proteoglycan filaments. Less than 1% of the interstitial volume is free-floating fluid. There is very little free flow of fluid through the interstitial space. Instead, fluid movement is a function of diffusion. Next is a discussion on the lymphatic system. You can think of the lymphatic system as a fluid scavenger. It removes fluid, protein, bacteria, and debris that has entered the interstitium. It accomplishes this goal with a pumping mechanism that propels lymph through a vessel network lined with one-way valves. This creates a negative pressure, or a net negative pressure, in the interstitial space. Lymph is returned to venous circulation by way of the thoracic duct at the juncture of the internal jugular and subclavian vein. You can injure the thoracic duct during venous cannulation. Since the thoracic duct is larger on the left side, there is a greater risk of chylothorax during left-sided internal jugular insertion. For completeness, you should know that there is a much smaller thoracic duct at the junction of the right IJ and subclavian veins, and it drains lymph from the right upper extremity, right thorax, and right side of the head. Again, this duct is much smaller and often omitted from textbooks. Edema occurs when the rate of interstitial fluid accumulation is exceeded or exceeds the rate of removal by the lymphatic system. So edema is basically the rate of interstitial fluid accumulation exceeding the rate of removal by the lymphatic system. Fluid that accumulates in potential space is called an effusion, such as a pleural effusion. Next, we're going to talk about the 4 O's. This is osmosis, osmotic pressure, osmolarity, and osmolality. This can be a tricky subject. If it helps, you can accept a few truths before moving forward. So you need to know that the semi-permeable membranes separate the body's compartments. Most solutes, meaning ions, proteins, and glucose, don't diffuse across these semi-permeable membranes. Instead, carrier proteins transport them from one side to the other. And lastly, you need to remember or know that water freely passes through these membranes. Since water likes to follow solute, it travels from areas of low solute concentration to areas of high solute concentration. Now that we have that down, let's dig into some concepts. So starting with osmosis, this is the net movement of water across a semi-permeable membrane. The direction of water is driven by the difference in solute concentration on either side of the membrane. Water tends to move from areas of low solute concentration to areas of higher solute concentration. For example, when we administer IV fluid, the water in the fluid diffuses across the blood vessel walls and equilibrates with the extracellular volume. This is illustrated in the picture below, which shows that in a non-permeable membrane, nothing equilibrates. This is no movement. In the middle is osmosis, so this has a semi-permeable membrane where only solvent equilibrates. And then all the way to the right, there is a fully permeable membrane. This is where solvent and solute equilibrate, and this is diffusion. Next, we're going to talk about osmotic pressure. This is the pressure of a solution against a semi-permeable membrane that prevents water from diffusing across the membrane. Osmotic pressure is a function of the number of osmotically active particles in a solution, meaning the amount of ionization. It is not a function of their molecular weights. Osmolarity and osmolality. These are measured of concentration. So these are two different measures of concentration. Osmolarity measures the number of osmoles per liter of the solution, and osmolality measures the number of osmoles per kilogram of the solvent. For our purposes, the difference between osmolarity and osmolality are so minuscule that we're going to pretend like they're the same thing, but if you're wondering, it's easier to think about body fluids using volume, liters, and osmolarity, than to think about them in terms of weight, kilograms, and osmolality. Since the body's fluid compartment are pretty dilute, it makes a little difference which one we choose, and knowing is half the battle. Regarding plasma osmolarity, this is normally 280 to 290 milliosmoles per liter. So plasma osmolarity is usually 280 to 290 milliosmoles per liter. And we can calculate this value with the following equation. Osmolarity, meaning plasma osmolarity, equals the sodium times 2 plus glucose divided by 18 plus Bun divided by 2.8. From this equation, you can see that sodium is the most important determinant of plasma osmolarity. You should also know that hyperglycemia or uremia can increase plasma osmolarity. Next is a discussion on tonicity. This compares the osmolarity of a solution relative to the osmolarity of the plasma. Remember that plasma is the reference point that we use to make the comparison. Since plasma is isotonic to cells, we can think about tonicity another way. We can use it to compare the tonicity of the solution to the tonicity of the cells. This is illustrated in the picture below that has hypotonic on the left, isotonic in the middle, and hypertonic on the right. So starting with the normal cell, which is surrounded by a normal osmolarity outside of 285 milliosmoles per liter. To the left, you have hypotonic, so the surrounding fluid you can see is 255 milliosmoles, and the solution is hypotonic to the cells, so water enters and the cell swells. In the middle, you have isotonic, so the fluid around it is the same, it's 285. Since the solution is isotonic to the cells, no water transfers and the cell remains the same exact size, as you can see. And then all the way to the right, there's hypertonic, which is 315 milliosmoles surrounding the cell. Solution is hypertonic to the cell, therefore water exits the cell and shrinks. We'll get into examples on each of these. So an example of crystalloid hypotonic solution is half sodium chloride, so 0.45% sodium chloride, which has an osmolarity of 154. There's also D5W, which has an osmolarity of 253. Compare this to 285, and these are both hypotonic. Next are isotonic crystalloids. So these include normal saline, so 0.9% sodium chloride, with an osmolarity of 308. There's also lactated ringers with an osmolarity of 273 and plasmolite A with an osmolarity of 294. Hypertonic crystalloids include 3% sodium chloride with an osmolarity of 1026, D5 normal saline, which has an osmolarity of 560, D5 half normal saline, which has an osmolarity of 405, and D5LR, which has an osmolarity of 525. There's also colloids, which do not have any hypotonic solutions, so all colloids are either isotonic or hypertonic. Starting with isotonic colloids, this includes albumin 5% with an osmolarity of 300, and hypertonic colloids includes dextran 10% with an osmolarity of 350. There's also isotonic colloids Voluven 6% and Hespan 6%. Hypotonic solutions have a lower osmolarity than plasma or cells, and these fluids are the same thing as giving free water. And this water freely distributes throughout all the body compartments. This explains why hypotonic solutions are poor expanders of the intravascular volume and why you should never give a hypotonic solution to a patient with an increased ICP. Some of you are probably thinking that glucose and D5W should be considered osmotically active. Well, you're half right. You're right because the glucose contributes osmotically active molecules to the plasma. The other side of the story is that this glucose is metabolized to carbon dioxide and water, and so what's left over? Water, and this is hypotonic. So the glucose is metabolized to carbon dioxide and water, the water is left over, and this is hypotonic. Regarding isotonic solutions, these have an osmolarity that is very close to the plasma or cells, and these solutions expand the plasma volume and the extracellular volume. Crystalloids tend to remain in the intravascular space for about 30 minutes. Sodium chloride can cause a hyperchloremic metabolic acidosis if it's given in large amounts. The lactate and lactated ringers functions as a buffer, and it is converted to bicarb by the liver and kidneys. So lactate is converted to bicarb by the liver and kidneys. Hypertonic solutions include those that have an osmolarity that exceeds the plasma or cells, and these solutions expand the intravascular volume by pulling fluid from the ICF into the ECF. Hypertonic saline is useful for treating cerebral edema as well as correcting hyponatremia. Myelinolysis can result if sodium is replaced too quickly. More on this in the brain tutorial under CNS 1. The following covers crystalloids versus colloids. So advantages of colloids include that the replacement ratio is 1:1. It increases plasma volume for 3 to 6 hours. Smaller volume is needed. There's less peripheral edema. Albumin has anti-inflammatory properties to it, and dextran 40 reduces blood viscosity, which improves microcirculatory flow in vascular surgery. Crystalloids advantage include a replacement ratio of 3:1 and expands the extracellular fluid, and it restores third space losses. Existence of the third space is debatable. Disadvantages of colloids. So natural colloids, albumin binds to calcium and can lead to hypocalcemia. Synthetic colloids, there's an FDA black box warning on synthetic colloids because of the risk of renal injury. And it can cause coagulopathy, so dextran greater than hetastarch, which is greater than Hextend. Don't exceed 20 mL per kg, and this is not a problem with Voluvin. There's also an anaphylactic potential, and the highest risk is with dextran. Regarding crystalloids, disadvantages include limited ability to expand the plasma volume. It increases plasma volume for about 20 to 30 minutes, and there's a higher potential for peripheral edema. Large volume of sodium chloride can lead to hyperkalemic metabolic acidosis. This is because an increase in chloride results in an increase in bicarb excretion by the kidney. There's also a dilutional effect on albumin, which reduces capillary oncotic pressure, and there's also a dilutional effect on coagulation factors. Albumin is the only colloid that is derived from human blood products. It does not contain antibodies, nor does it increase the risk of an infectious disease transmission. Next is a review of electrolytes. This is a long page with a lot of details in these tables, so this will be read through kind of quickly, and it might be better just to go back and do flashcards on some of these. So let's start with hyponatremia and hypernatremia. Hyponatremia is a sodium of less than 135 milliequivalents per liter. Hyponatremia may exist in various states of hydration, such as hypovolemic, isovolemic, and hypervolemic, so you must evaluate plasma osmolarity and ECF volume to determine the cause. Decreased total body sodium content is due to diuretics, salt wasting disease, and hypoaldosteronism. Normal total body sodium content can be caused by SIADH, hypothyroidism, water intoxication, and periop stress. If there's an increased total body sodium content, think CHF and cirrhosis. Regarding hypernatremia, this is a sodium level greater than 145 milliequivalents per liter, and hypernatremia may exist in various states of hydration as well, such as hypovolemic, isovolemic, and hypervolemic. So you, again, must evaluate the plasma osmolarity and ECF volume to determine the cause. Decreased total body sodium content can be from osmotic diuretics, nausea, vomiting, and adrenal insufficiency. Normal total body sodium content can be a result from diabetes insipidus, renal failure, and diuretics, and increased total body sodium content can be due to hyperaldosteronism and increased sodium intake, or, for example, a 3% saline infusion. So the presentation of hyponatremia includes signs that are based on plasma sodium concentration. So 130 to 135 is no signs to maybe mild signs. 125 to 129 is nausea, vomiting, and malaise. 115 to 124 is headache, lethargy, and altered level of consciousness. And 115 or less if it's rapid onset, so 115 or less, or if it's a rapid onset, results in seizures, coma, cerebral edema, and respiratory arrest. Treatment depends on the specific cause. So treatment of hyponatremia depends on the specific cause. The goal is to restore sodium balance with manipulating serum osmolality and fluid balance with water restriction. IV fluid selection is based on tonicity, and you can also treat with diuretics. Regarding hypernatremia, this is also based on serum osmolality. So hyponatremia is based off of plasma sodium concentration, and hypernatremia is based on serum osmolality. 350 to 375 is a headache, agitation, and confusion. 376 to 400 is weakness, tremors, and ataxia. 401 to 430 is hyperreflexia and muscle twitching, and 431 or more can result in seizures, coma, and death. Treatment, again, depends on the specific cause. The goal is to restore sodium balance by manipulating the serum osmolality and fluid balance with sodium restriction. IV fluid selection based on tonicity, and again, is also treated with diuretics depending on what the cause of the hypernatremia is. Next is hypokalemia. So this is defined as less than 3.5 milliequivalents per liter. It can be caused by poor potassium intake from diet, GI loss, so this is vomiting and diarrhea, nasogastric suction, Zollinger-Ellison syndrome, jejunal-ileal bypass, so this is malabsorption, and K-oxalate. Renal loss includes diuretics, metabolic alkalosis, and licorice. Redistribution happens when potassium shifts the cell intracellularly, so potassium shifts into the cell intracellularly. This can be caused by insulin and D50, hyperventilation bicarb, beta-2 agonist, which is albuterol, and hypokalemic periodic paralysis. The presentation is skeletal muscle cramps resulting in weakness, leading to paralysis. And you should also know that hypokalemia worsens digoxin toxicity. EKG findings include a long PR interval and a long QT interval. The T wave becomes flat and there is a U wave. Treatment includes potassium supplementation unless the etiology is redistribution. So next we're going to talk about hyperkalemia, which is defined as a serum potassium greater than 5.5 milliequivalents per liter. So this can happen from increased potassium intake, potassium administration, potassium-containing medications, and bank blood, or impaired potassium excretion, such as acute oliguric renal failure, chronic renal disease, hypoaldosteronism, and drugs that impair potassium excretion, such as NSAIDs, spironolactone, and triampterine. Redistribution can also cause hyperkalemia, and this is when potassium shifts into the extracellular space. So this happens with either metabolic or respiratory acidosis, succinylcholine, beta blockers, and hyperkalemic periodic paralysis. Cellular injury can also cause hyperkalemia from tumor lysis. This happens during chemotherapy. Hemolysis, burns, crush injury, and rhabdomyolysis. Can also be caused by pseudohyperkalemia, which is hemolysis of a blood specimen. Presentation includes cardiac rhythm disturbances, and EKG findings is based on serum potassium concentration. So 5.5 to 6.5, you'll have some peak T waves. 6.5 to 7.5, you'll have P flattening and PR prolongation. 7 to 8 is QRS prolongation, and 8.5 or greater, the QRS turns into the sine wave, and it leads to ventricular fibrillation. Treatment of the hyperkalemia includes cardiac membrane stabilization with calcium and redistribution, so the potassium, you're going to try to shift it intracellularly with insulin and D50 or hyperventilation or bicarb or beta-2 agonists, such as albuterol. And then also promote elimination. So you're going to give potassium-wasting diuretics, K-oxalate, and potentially dialysis. Next is a discussion on calcium. So hypocalcemia is defined as a calcium level less than 8.5 milliequivalents per liter. Etiology includes hypoparathyroidism, vitamin D deficiency, renal osteodystrophy, and pancreatitis and sepsis. Presentation of hypocalcemia include skeletal muscle cramps, nerve irritability, paresthesia and tetany, laryngospasm, mental status changes resulting in seizures, Chvostek's sign, and Trousseau's sign. EKG findings include a long QT interval, and treatment is, of course, with calcium and also vitamin D. Hypercalcemia is defined as a serum calcium level greater than 10.5 milliequivalents per liter. Etiology is hyperparathyroidism, cancer, thyrotoxicosis, thiazide diuretics, and immobilization. Presentation includes nausea, abdominal pain, hypertension, psychosis, and mental status changes leading all the way up to seizures. EKG findings include a short QT interval, so as the calcium goes up, the interval goes down, and vice versa. And treatment is with normal saline, so 0.9% sodium chloride, and loop diuretics such as Lasix. Next is magnesium. Hypomagnesemia is a serum level less than 1.8 milligrams per deciliter or 1.5 milliequivalents per liter. Etiology includes poor intake, alcohol abuse, diuretics, critical illness, and it is commonly seen with hypokalemia. Presentation is listed in a table below that's kind of detailed. EKG findings are not significant unless very low, in which case it can prolong the QT interval. Treatment is with mag sulfate supplementation. Hypermagnesemia is with a plasma level greater than 2.5 milligrams per deciliter or greater than 2.1 milliequivalents per liter. Etiology is excessive administration, renal failure, or adrenal insufficiency. So again, we're going to refer to the table below for a second for presentation. EKG findings are also not significant unless very high, which can lead to a hard block. You treat this with calcium chloride or gluconate. So this table lists the signs and symptoms of magnesium toxicity, either low or high, I should say. So normal is 1.8 to 2.5, and this is in milligrams per deciliter. 1.5 to 2.1 milliequivalents per liter, or 0.75 to 1.05 millimoles per liter. I am just going to go with milligrams per deciliter all the way to the left because the other ones are the same presentation. It's just different numbers depending on if you want to measure it by milliequivalents or millimoles. So starting with milligrams per deciliter, hypomagnesemia. So less than 1.2 milligrams per deciliter leads to tetany, seizures, and dysrhythmias. 1.2 to 1.8 leads to neuromuscular irritability, hypokalemia, and hypocalcemia. And next is hypermagnesemia. So typically there's no symptoms between 2.5 and 5. This is again milligrams per deciliter. And you have diminished deep tendon reflexes, lethargy, and drowsiness, flushing, and nausea, vomiting. And this is all with a level of 5 to 7 milligrams per deciliter. From 7 to 12 milligrams per deciliter, you have a loss of DTRs, you have hypotension, EKG changes, somnolence. And greater than 12 equals respiratory depression leading up to apnea. You can have complete heart blocks, cardiac arrest, comas, and paralysis. And that concludes our talk on electrolytes. Moving on to acid-base disturbances. This is going to be an overview. Cellular and enzymatic function are highly sensitive to pH. Therefore, any condition that alters pH can affect homeostasis. The body attempts to regulate blood to a pH of 7.4. Normal is 7.35 to 7.45. Acidosis is, of course, less than 7.35, and alkalosis is greater than 7.45. The Henderson-Hasselbalch equation says that the solution's pH is a function of the ratio of dissociated anion, represented by A negative, to the non-dissociated acid, represented by HA. And this equation you can see in the table where pH equals pK plus the log of anions divided by non-dissociated acids. So pH equals pK plus the log of A minus divided by HA. You can also use the formula pH equals pK plus log of bicarb divided by CO2. The following picture depicts the erythrocyte and externally surrounding plasma, and it shows the function of carbonic anhydrase, taking CO2, adding water. Carbonic anhydrase creates bicarb, or carbonic acid, I should say. This is the H2CO3, which dissociates into a proton and bicarb. The proton is added to hemoglobin as a buffer, and the bicarb is transported extracellularly into the plasma in exchange for chloride, and this buffer is for the outside, and the chloride moves in just to maintain electroneutrality. Buffer systems help mitigate changes. So some of these systems include blood, respiratory compensation, and renal compensation. So blood is bicarb buffer. This is the most important. Hemoglobin is the second most important blood buffer. Regarding respiratory, so naturally altering ventilation can change the PaCO2, which is considered a volatile acid. And renal compensation, so reabsorption of filtered bicarb plays a role. Removal of titratable acids, which are non-volatile acids. And then there's also the formation of ammonia. So how to evaluate acid-base balance on an ABG? You need to ask 5 questions. Is the pH normal? 7.35 to 7.45. Is the PaCO2 normal? 35 to 45. Is the bicarb normal? 22 to 26. And then you apply Rome, respiratory opposite, metabolic equal. And then the last question, the 5th question that you need to ask, has compensation occurred? So the mnemonic Rome, again, is respiratory opposite, and this is used to help you remember that PaCO2 moves opposite to the direction of pH. So as pH goes up, PaCO2 goes down. And then metabolic equal, bicarb moves pH in the same direction. Regarding compensation, full compensation restores pH to normal, whereas partial compensation moves pH to towards normal, but the pH is still abnormal. Mixed metabolic disorders, or mixed disorders, I should say, are possible. For example, a patient with sepsis who received excessive sedation could have a mixed metabolic and respiratory acidosis. So the metabolic is from the sepsis, however, the excess sedation leads to a respiratory acidosis as well. So you can see the table above with the primary problem, how the pH changes, and compensation. You can review that for further clarity. And next we're going to review some consequences of acid-base imbalance. So this includes cardiac effects of acidosis. So the P50 is increased, meaning it moves it right, allowing more oxygen to be released from hemoglobin. So think right equals released. Acidosis causes an increase in SNS tone, there's an increased risk of dysrhythmias, and there's a decreased contractility. Cardiac effects of alkalosis includes a decrease in P50, so think left equals love. Less oxygen is able to be freed from hemoglobin. There's also decreased coronary blood flow and an increased risk of dysrhythmias. So both of these have an increased risk of dysrhythmias. Regarding CNS effects of acidosis, there's an increase in cerebral blood flow and an increase in ICP. And vice versa with alkalosis, there's a decrease in CBF and a decrease in ICP. Pulmonary effects of acidosis include an increase in pulmonary vascular resistance, and likewise alkalosis decreases pulmonary vascular resistance. Other effects are hyperkalemia is associated with acidosis, whereas hypokalemia is associated with alkalosis, which manifests as a decrease in ionized calcium. Next, we're going to talk about acid-base disturbances, specifically with the respiratory system. So respiratory acidosis occurs when alveolar ventilation is unable to keep up with CO2 production. There are three etiologies. There's an increase in CO2 production or a decrease in CO2 elimination, and then there's also rebreathing. Treatment is aimed at reversing the underlying cause. A pH of less than 7.2 is an indication for mechanical ventilation. PaCO2 equals CO2 production divided by alveolar ventilation. So the arterial content of CO2, meaning or I should say the arterial pressure of CO2, which is the PaCO2, equals the CO2 production divided by the alveolar ventilation. This is what determines your arterial CO2. Hypercapnia is PaCO2 greater than 45 millimeters of mercury, and hypocapnia is a PaCO2 less than 35 millimeters of mercury. Example causes of hypercapnia include increased CO2 production from sepsis, overfeeding, MH, intense shivering, prolonged seizure activity, thyroid storm, and burns. Examples of decreased CO2 elimination causing hypercapnia include airway obstruction, increased dead space, increased BD divided by VT, so increased dead space relative to your tidal volume. ARDS, COPD, respiratory center depression, drug overdose, inadequate neuromuscular block reversal, and rebreathing. So this is, for example, an incompetent one-way valve or exhausted soda lime. So how does a change in PaCO2 affect pH? It can be acute respiratory acidosis, which results in increased 10 millimeters of mercury, which decreases the pH by 0.08. So again, the relationship that you need to know for acute respiratory acidosis is that an increase in 10 millimeters of mercury of PaCO2, that's arterial partial pressure of CO2, will decrease your pH by 0.08. Regarding chronic respiratory acidosis, the relationship is an increase in PaCO2 will decrease pH by 0.03, and this is due to the retention of bicarb from your renal system, and this occurs in chronic respiratory acidosis. Regarding metabolic compensation, during respiratory acidosis, the kidneys excrete hydrogen and conserve bicarb to return the pH to normal. This process begins within hours, but may require several days for full compensation to occur. Consequences of respiratory acidosis are listed in the table below. Hypoxemia. So remember the alveolar gas equation. Alveolar nitrogen is inert and its concentration remains constant. An increase in alveolar CO2 displaces alveolar oxygen, resulting in arterial hypoxemia. An increase in P50 also occurs, and this shifts the curve to the right. So an increased P50 means that the dissociation curve is shifted to the right, meaning more oxygen is released to the tissues. This partially compensates for the hypoxemia created by CO2 displacing alveolar oxygen. Cardiac and smooth muscle can also be depressed, and this is because acidosis inside the muscle affects the contractile protein and enzymatic function, leading to myocardial depression and vasodilation. SNS stimulation can also occur, and this is because CO2 activation is responsible for increasing the sympathetic nervous system and increasing catecholamine release. Unless the acidosis is severe, SNS stimulation offsets cardiac and smooth muscle depression. So tachycardia results in increased myocardial oxygen consumption and decreased myocardial oxygen delivery. Vasoconstriction results in increased systemic vascular resistance and increased myocardial oxygen consumption. Dysrhythmias can also occur due to SNS stimulation, and there's a prolonged QT interval. The oculocardiac reflex is more common following a precipitating event. So hypercarbia results in SNS stimulation, which actually makes the oculocardiac reflex more common to occur with a precipitating event. There's increased alveolar ventilation, and this is due to CO2 being a respiratory stimulant, which increases the amount of ventilation. There's also increased potassium, and this is because the CO2 activates the hydrogen potassium pump, and this buffers CO2 acid in exchange for releasing potassium into the plasma. There's an increase in calcium. This is because ionized calcium competes with protons for binding spots on plasma proteins. So if you have an increase in CO2, then you're going to have an increase in protons, which binds to plasma proteins and competes with calcium. So this is why calcium gets kicked off proteins and it is increased. Acidosis occurs and plasma proteins buffer hydrogen and release calcium, which increases inotropy. Likewise, alkalosis, plasma proteins release hydrogen and bind to calcium, which decrease inotropy. So all that is kind of just different ways of saying the same thing. Regarding increased ICP and hypercarbia, so CO2 freely diffuses across the blood-brain barrier. There's a decreased CSF pH, which decreases cerebrovascular resistance and increases CBF and volume. So it increases cerebral blood flow and the volume. And lastly, there's hypercarbia can cause a depression or a decreased level of consciousness. So CO2 narcosis occurs when the PaCO2 is greater than 90 millimeters of mercury. Hypercarbia has the opposite effect on pulmonary blood vessels than in the circulation. In the lungs, CO2 is a direct-acting vasoconstrictor. So CO2 is a direct-acting constrictor in the lungs, where it can cause pulmonary hypertension and increase the right ventricular workload. Do not correct PaCO2 in a patient with chronic respiratory acidosis, so for example, COPD. These patients normally retain bicarb, and if you return their CO2 to normal, then you've created a metabolic alkalosis. Respiratory alkalosis occurs when alveolar ventilation exceeds CO2 production. Physiologically, it has the opposite effect of respiratory acidosis. Causes include iatrogenic, such as mechanical ventilation, and this is the most common cause, hypoxia, such as high altitude, low FiO2, and profound anemia, pain, anxiety, pregnancy, pulmonary embolism, and reduced mechanical dead space with the same alveolar ventilation. So the example is removing the HME or changing from mask to endotracheal tube. There are also some drugs such as progesterone, salicylates, and aspirin. Metabolic compensation includes the kidneys that excrete bicarb to return pH to normal, but this can take several days. And there are some consequences of respiratory alkalosis, including cardiovascular, CNS, and electrolytes. So cardiovascular include dysrhythmias, a decreased coronary blood flow, decreased myocardial contractility, and a decreased P50, meaning a leftward shift of the oxyhemoglobin dissociation curve. Regarding CNS, there is an inhibition of respiratory drive. There's cerebral vasoconstriction, so decreased cerebral blood flow and decreased ICP. There's neuronal irritability, confusion. And then regarding electrolytes, so alkalosis causes a decrease in serum potassium and a decrease in calcium, so decreased serum calcium. The best treatment is to reverse the underlying cause. In the spontaneously ventilating patient, respiratory alkalosis can be treated with sedation. There's a concern whenever the pH is greater than 7.6. In the mechanically ventilated patient, respiratory alkalosis is treated by reducing ventilation on the ventilator. Next, we're going to talk about acid-base disturbances with a focus on metabolic disturbances. So metabolic acidosis is characterized by a pH less than 7.35 as a result of accumulation of non-volatile acids, loss of bicarb, and or large volume resuscitation with a sodium chloride solution. The anion gap helps us determine the cause of acidosis. So an anion-ion gap equals the major cations minus the major anions. So this is basically your sodium minus your chloride plus your bicarb. So you take your chloride, you add it to your bicarb, and then you subtract this from your sodium. Normal is 8 to 12. There's an accumulation of acid that results in a gap acidosis, so an anion gap acidosis. The loss of bicarb or extracellular fluid dilution results in a non-gap acidosis. So those are the two types of metabolic acidosis. So regarding an anion gap acidosis, it's a pH less than 7.35 and an anion gap greater than 14. Non-gap acidosis, you have a pH less than 7.35 and your anion gap is less than 14. The etiology of an anion gap acidosis can be remembered with the mnemonic mud piles. So the M is methanol, U is uremia, D is diabetic ketoacids, P is paraldehyde, I is isoniazid, L is lactate. So this results in a decreased DO2, sepsis, and cyanide poisoning. Or a lactate, I should say a lactate can be caused by a decreased DO2, sepsis, or cyanide poisoning. The E is for ethanol and ethylene glycol, and the S is for salicylates because it inhibits the Krebs cycle. And then examples of a non-gap acidosis, the mnemonic hard up can be used to remember the etiology. So the H is hypoaldosteronism, the A is acetazolamide, the R is renal tubular acidosis, the D is diarrhea, and the U is uridosigmoid fistula, and then the P is for pancreatic fistula. Large volume resuscitation with sodium chloride solutions can cause a non-gap metabolic acidosis with hyperchloremia. Regarding respiratory compensation, PaCO2 decreases as a function of increased minute ventilation. PaCO2 decreases 1 to 1.5 millimeters of mercury for every bicarb decrease of 1 milliequivalent. So that's interesting. You could probably just remember 1 to 1. Your bicarb decreases 1 by every 1 decrease in millimeters of mercury of your arterial partial pressure of CO2. Technically, it's every 1 to 1.5, though, like we said. Treatment, so talking about the anion gap acidosis, you need to treat the underlying cause. Lactic acidosis should be treated with IV fluids, oxygen, and cardiopulmonary support. Diabetic ketoacidosis is, of course, treated with IV fluids and insulin. Uremia or drug-induced anion gap acidosis is treated with dialysis. Sodium bicarb used for anion gap acidosis is controversial. It's best used as a temporary measure if the pH is less than 7.2 and the patient is hemodynamically unstable. Enzymes in the body don't work well in an acidic environment. So again, this is a temporary fix to facilitate enzymatic function until you can treat the true underlying cause. Also, sodium bicarb can cause intracellular acidosis in the setting of an inadequate ventilation or perfusion. Regarding non-gap acidosis, you also treat the underlying cause. Sodium bicarb is useful because most of the etiologies produced bicarb loss. So that's the difference between gap and non-gap. So non-gap, your sodium bicarb is actually the go-to treatment. Metabolic alkalosis is characterized by a pH greater than 7.45. It is caused by increased bicarb and or a loss of non-volatile acids. So the etiology of an addition of bicarb includes sodium bicarb administration and massive transfusion because the liver converts preservatives to bicarb. The etiology of the loss of non-volatile acid include the loss of gastric fluid, which is the most common. So this is vomiting in nasogastric suction. You can also lose acid in the urine. Diuretics can be an etiology, and extracellular depletion results in increased sodium reabsorption, which results in proton and potassium excretion in order to maintain electroneutrality. And then the etiology of increased mineral corticoid activity, examples of this is Cushing syndrome and hyperaldosteronism. All of these can cause metabolic alkalosis. Regarding respiratory compensation, so the PaCO2 increases as a function of a decreased minute ventilation. PaCO2 increases as a function of decreased minute ventilation to compensate for your metabolic alkalosis. PaCO2 increases 0.5 to 1 millimeter mercury for every bicarb increase of 1 milliequivalent per liter. Treatment is focused on correcting the underlying cause. Acetazolamide is a carbonic anhydrase inhibitor, and it actually increases the renal excretion of bicarb. Spironolactone is a mineralocorticoid antagonist and can be used. And then there's also, of course, dialysis. Next, we're going to talk about perioperative goals for administering fluid therapy. So this is peri-op goal-directed fluid therapy. The classic approach to peri-op fluid management is plagued by, among other things, arbitrary fluid replacement calculations and a lack of specific and clear endpoints of volume resuscitation. Fluid balance is just that. It's a balance between too little and too much. Inadequate circulating volume reduces cardiac output and oxygen delivery, and excessive circulating volume promotes microvascular congestion, which also impairs oxygen delivery. Indeed, optimizing oxygen delivery is the fundamental objective of goal-directed fluid therapy. So take a moment to review the consequences of inappropriate fluid administration as well as the benefits of peri-op goal-directed therapy. So too little volume resuscitation results in decreased circulatory volume, so hypovolemia, decreased oxygen delivery, this is due to impaired microcirculatory perfusion, decreased organ perfusion, hemoconcentration, which increases blood viscosity, myocardial ischemia, renal impairment, and PONV. This is all from hypovolemia, too little volume resuscitation. Too much volume resuscitation includes excessive circulatory volume, this is hypervolemia, decreased oxygen delivery, this is from microvascular congestion, impaired glycocalyx, hemodilution, so hemoglobin coagulation factors and plasma proteins are all diluted, increased extravascular lung water, so this is impaired gas exchange, impaired wound healing, this increases the risk of infection, increased risk of ventilator-associated pneumonia, abdominal compartment syndrome, liver congestion, impaired gut function, so slower gastric emptying and ileus are byproducts of impaired gut functioning. And the balance here is depicted in these pictures. So on the left you have preload and stroke volume, and on the right you have intravascular volume and complications. So these are just sort of visual illustrations of what we talked about. So if you have your target preload, which is represented in the middle here, number 2, then you have optimal stroke volume. But if you exceed your preload by giving too much fluid, then there's actually a decrease in your stroke volume, albeit it's a slower downslope than your increase, but still you can actually impair stroke volume with excessive preload. And then on the right, the rates of complication relative to fluid balance. So too little hypoperfusion, you have an increase in complications, and too much, you have edema. And next we're going to talk about the Starling curve. We kind of touched on this earlier. The goal-directed fluid therapy attempts to optimize the patient's position on the Starling curve. So number 1 is the slope. There's basically a few elements, 3 elements to the Starling curve. So number 1 is the slope. When the patient resides on the lower portion of the Starling curve, additional fluid increases the sarcomere stretch, and this increases the cross bridge formation, resulting in a greater cardiac output. This is called preload dependence. Said another way, this patient is volume responsive and is a candidate for additional volume resuscitation. The second is the plateau. The plateau suggests the optimal balance between circulating volume and myocardial performance. This is called preload independence. Additional fluid would not be expected to improve hemodynamics or oxygen delivery. Furthermore, it might cause harm. And then the third category here is overshoot. Overshooting the curve impairs the myocardial performance, placing the patient at risk of pulmonary edema and congestive heart failure. A key principle of goal-directed therapy is the administration of small quantities of fluid, so about 200 to 250 milliliters, to determine the difference between the preload dependence and the preload independence. This will vary from patient to patient. Emerging technologies such as pulse contour monitoring, as well as esophageal Doppler, covered in Unit 6 under hemodynamic monitors, aids in the provision of optimal fluid management. So if you want to learn more about the esophageal Doppler, go to Unit 6. Under hemodynamic monitors. And because fluid balance can change acutely during surgery, you'll need to monitor indices of preload responsiveness throughout the procedure. Also, it's critical to understand that in a patient with poor ventricular function, a small volume of fluid may be enough to push the patient from preload independence to pulmonary edema. Next, we're going to talk about enhanced recovery after surgery. So originally, this is designed to enhance outcome for patients undergoing colon surgery. We are witnessing enhanced recovery after surgery programs pushed into a wider variety of other surgical populations. The primary objective is to enhance post-surgical outcomes with a standardized approach to perioperative care. This is accomplished with techniques that do the following. So these techniques are meant to attenuate the physiologic change that accompanies surgical trauma, minimize the impact of fluid shifts, maximize the nutritional impact of healing, improve post-op pain so the patients can recover faster, and improve patient education and compliance. While protocols differ from hospital to hospital, there are a variety of components common to nearly all ERAS programs. Some of these guidelines challenge long-standing dogma, where the provision of clear fluids up to 2 hours of surgery is a prime example. Take some time to familiarize yourself with the key components of ERAS. So there's pre-op considerations, including this is typically things that are under the control of anesthesia, and this includes pre-admission counseling, fluid and carb loading, fasting, meaning 2 hours fluids and 6 hours solid, antibiotic prophylaxis, avoidance of pre-medication. However, there's some preoperative that are not under the control of anesthesia, such as no use of bowel prep and thromboprophylaxis. Typically, intraoperative factors that are under control of anesthesia include mid and thoracic epidural anesthesia, selecting short-acting drugs, goal-directed fluid therapy, normothermia, and POV prophylaxis. However, not under the control of anesthesia is not using surgical drains. So intraoperative ERAS that is not under the control of anesthesia is you really want to avoid the use of surgical drains. Post-op ERAS protocols that are under the control of anesthesia include mid-thoracic epidural anesthesia, again, because you can do that intra-op or post-op. Opioid-sparing analgesia, so talking about multimodal management here. Judicious fluid administration, PONV prophylaxis. However, there's a few that are not under the control of anesthesia in the post-op period, and this include not using an NGT tube or an OG tube, encouraging gut motility, early oral intake of nutrition, and early removal of urinary catheters, early ambulation, and post-op counseling and follow-up. These are all not under control of anesthesia. If using epidural anesthesia, the patient should have a good function of lower extremities to encourage early ambulation.